If you want to understand why so many people over 60 are being hospitalized, not because their conditions got worse, but because the medications meant to protect them are quietly causing organ damage, cognitive decline, and falls that lead to fractures, don't look at the diseases themselves. Look at what's sitting in their medicine cabinet every single morning. Hi, I'm Dr. Liana. I'm an emergency medicine physician and geriatric pharmacology researcher. And what I'm about to share with you comes from nearly 15 years working the front lines, where I've watched the same preventable pattern repeat itself week after week. Otherwise, healthy seniors rushed in with sudden confusion, dangerous bleeding, kidney failure, or devastating falls. And when we check their medication list, the culprit isn't some rare reaction. It's a drug their doctor put them on years ago that should have been stopped the moment they turned 60. Here's a number that should stop you cold. A landmark study published by researchers analyzing data from over 12,000 adults aged 65 and older found that 48% of seniors are taking at least one medication that poses more risk than benefit at their age. Nearly half. That means if you're over 60 and taking 5 medications, statistically, 2 of them are quietly working against you. And here's what makes this so dangerous. Most doctors are so focused on treating individual conditions, high blood pressure, cholesterol, acid reflux, that they never step back to ask whether the cumulative burden of these medications is destroying quality of life faster than the conditions themselves ever would. The medical term for this is polypharmacy. The result is a cascade of side effects that get mistaken for normal aging when they're actually drug-induced decline. Most people over 60 have been told that once you start a medication for blood pressure or cholesterol or blood sugar, you're on it for life. That stopping a medication is dangerous. That these drugs are keeping you alive and discontinuing them would be reckless. But after nearly 30 years studying how medications behave differently in aging bodies, and after reviewing thousands of cases where medication reduction dramatically improved patient outcomes, I've come to understand something that quietly contradicts that belief. Your body at 65 is fundamentally different from your body at 45. Your liver doesn't metabolize drugs the same way. Your kidneys don't filter medications at the same rate. Your brain chemistry responds differently to compounds that were perfectly safe 2 decades ago. And yet, the standard medical approach treats a 70-year-old body like it's just an older version of a 40-year-old one, when the reality is that certain medications that were protective in midlife become actively harmful after 60. Think of your body's medication processing system like a water treatment plant. In your 40s and 50s, that plant is running at full capacity. Filters are clean, pumps are strong, waste gets cleared efficiently. You can handle 5, 6, 7 different chemical inputs without backup or overflow. But after 60, that plant starts operating at reduced capacity. The filters your kidneys get clogged. The main processing unit, your liver, slows down. Suddenly, those same 7 chemical inputs aren't getting cleared properly. They start accumulating. They start interacting with each other in ways they never did before. And the backup doesn't show up as a flashing warning light. It shows up as dizziness you blame on getting older, as memory problems you assume are early dementia, as weakness you accept as inevitable decline. The problem is that conventional medicine adds medications to address symptoms without asking whether previous medications caused those symptoms in the first place. You go on a blood pressure medication that makes you dizzy. Your doctor prescribes a medication for vertigo. That medication makes you nauseous. Now you're on an anti-nausea drug. That disrupts your sleep. Now you're on a sleep medication. And suddenly, you're taking 5 drugs to manage side effects of the first drug, when stopping the first drug and managing blood pressure through diet and movement would have prevented the entire cascade. Here's what most people never hear from their doctor. The evidence that justified starting many of these medications was based on studies of people in their 40s and 50s. The benefits demonstrated in those trials, reduced heart attack risk, stroke prevention, fracture reduction, don't necessarily apply to people over 70. In fact, for several major drug classes, the risks after 60 dramatically outweigh any potential benefit. Let me be very clear about what I'm not saying. I'm not suggesting you stop taking medications without medical supervision. I'm not claiming all medications are harmful after 60. What I am saying is that 5 specific medication categories commonly prescribed to seniors have mounting evidence showing they cause more harm than good after age 60, and yet they remain on millions of medicine cabinet shelves because no one has initiated the conversation about stopping them. And the 5 medications or medication classes I'm about to walk you through are sitting in cabinets across the country right now, taken faithfully every morning by people who have no idea that the fatigue they're experiencing, the mental fog, the increased fall risk, the digestive problems aren't aging. They're adverse drug effects that would resolve within weeks of discontinuation. Medication number 1, proton pump inhibitors. These are the acid-blocking medications most people know as Prilosec, Nexium, Prevacid, or omeprazole. Here's how you probably ended up on one of these. Maybe 15 years ago, you had heartburn, acid reflux, some stomach discomfort. Your doctor prescribed a PPI, probably told you to take it for a few weeks, and somehow, 15 years later, you're still taking it every single morning. Proton pump inhibitors work by shutting down the acid-producing pumps in your stomach lining. In the short term, for acute ulcers or severe reflux esophagitis, they're remarkably effective. But here's what happens when you take them for years, especially after 60. Your stomach produces acid for critical reasons. It's your first line of defense against foodborne pathogens. It's essential for absorbing calcium, magnesium, vitamin B12, and iron. It activates digestive enzymes that break down protein. When you chronically suppress that acid, you don't just reduce heartburn. You create a cascade of deficiencies and vulnerabilities. Mechanism 1, bone fracture risk through calcium malabsorption. Calcium absorption requires an acidic stomach environment. When you suppress acid production chronically, calcium passes through your digestive system without being properly absorbed. Researchers at Harvard Medical School, analyzing data from over 13,000 postmenopausal women tracked over 11 years, found that women using PPIs for more than 2 years showed a 35% increased risk of hip fracture compared to non-users. Think of your stomach acid like the key that unlocks calcium from food so your bloodstream can use it. Block that key, and the calcium you're eating in dairy, leafy greens, fortified foods just passes through while your bones slowly demineralize. Mechanism 2, dementia risk through vitamin B12 deficiency. Vitamin B12 also requires stomach acid for absorption. Chronic PPI use creates functional B12 deficiency, even when dietary intake is adequate. A study from Germany tracked over 73,000 patients aged 75 and older and found that those receiving regular PPI prescriptions showed a 44% increased risk of dementia compared to those not on PPIs. Now, B12 deficiency doesn't just contribute to dementia risk. It causes fatigue, peripheral neuropathy, balance problems, and depression, symptoms that often get attributed to normal aging when they're actually medication-induced and completely reversible. Mechanism 3, infection susceptibility. Your stomach acid kills bacteria, viruses, and parasites that enter through food and water. Suppress that acid, and you become vulnerable to infections you would have fought off effortlessly in your 40s. Research published analyzing over nearly 300,000 patients found that PPI users showed nearly triple the risk of Clostridium difficile infection, a severe and potentially life-threatening intestinal infection. They also showed increased risk of pneumonia, kidney infections, and small intestinal bacterial overgrowth. Here's what's particularly frustrating. For the vast majority of people over 60 taking PPIs, the original indication was mild reflux that could be managed through dietary modification, smaller meals, avoiding late-night eating, elevating the head of the bed. But once you're on a PPI for months, stopping causes rebound hyperacidity. Your stomach overproduces acid for a few weeks, making reflux temporarily worse. And that rebound convinces people they need the medication permanently quickly, when actually they just need to taper properly over 2 to 3 weeks. Medication number 2, benzodiazepines. These are the anti-anxiety and sleep medications known as Xanax, Ativan, Valium, Klonopin, and others. These medications work by enhancing a neurotransmitter called GABA that calms brain activity. In short-term use for acute anxiety or sleep disturbance, they can be helpful. But in people over 60, especially with chronic use, they become profoundly dangerous. Mechanism 1, fall and fracture risk through motor impairment and balance disruption. Benzodiazepines affect the cerebellum, the part of your brain that controls balance and coordination. In younger people, the effect is mild. After 60, when balance systems are already compromised and bone density is reduced, the effect is catastrophic. A meta-analysis examining data from over 48,000 older adults found that benzodiazepine use increased fall risk by 48%. And falls after 60 aren't minor incidents. A fall that results in hip fracture carries a 1-year mortality rate of nearly 24%. That means nearly 1 in 4 people who fracture a hip after 60 will be dead within a year, often from complications like pneumonia or blood clots that develop during the immobility of recovery. Mechanism 2, cognitive decline and dementia acceleration. Benzodiazepines suppress overall brain activity, including areas responsible for memory formation and executive function. A study from France following over 1,600 participants over 15 years found that benzodiazepine use for more than 3 months was associated with a 43 to 51% increased risk of dementia. Think of your brain like a city's electrical grid. Benzodiazepines dim the lights across entire neighborhoods. Do that chronically, and those neighborhoods start shutting down permanently. Mechanism 3, paradoxical effects and withdrawal dependency. In older adults, benzodiazepines often produce effects opposite to their intended purpose. Instead of reducing anxiety, they cause confusion, agitation, and emotional lability. Instead of improving sleep, they disrupt sleep architecture, reducing deep restorative sleep phases while increasing fragile light sleep. And after just 2 weeks of daily use, your brain becomes dependent. Stopping abruptly can trigger life-threatening withdrawal, including seizures. Yet millions of seniors are on these medications for years, sometimes decades, because no doctor has initiated a careful tapering protocol. Medication number 3, first-generation antihistamines. These include Benadryl, diphenhydramine, Unisom, doxylamine, and other over-the-counter sleep aids and allergy medications. Akiri NT, Atis or Wandi, Atize. Most people don't think of these as dangerous because they're available without prescription. But in people over 60, first-generation antihistamines are among the most cognitively damaging medications commonly used. These drugs block acetylcholine, a neurotransmitter critical for memory, attention, and learning. This anticholinergic effect is mild in younger brains. After 60, when acetylcholine levels are already declining, the effect is devastating. Research from the University of Washington, tracking over 3,500 participants aged 65 and older over 7 years, found that cumulative anticholinergic medication, use equivalent to taking Benadryl daily for 3 years or longer, was associated with a 54% increased dementia risk. The damage appears to be dose-dependent and potentially irreversible. Think of acetylcholine like the neurotransmitter that keeps your brain's filing system organized. Block it chronically, and files get misfiled, connections get lost, retrieval systems break down. The person taking Benadryl every night for sleep has no idea that the memory problems they're developing aren't Alzheimer's beginning. They're drug-induced cognitive impairment that would stabilize or partially reverse if the medication were stopped. These medications also cause urinary retention, constipation, dry mouth, blurred vision, and dangerously impaired driving ability. Yet they're used casually for seasonal allergies, occasional insomnia, cold symptoms, often by people who would never take a prescription sleeping pill, but don't realize the over-the-counter pink pill is potentially more dangerous. Medication number 4, non-steroidal anti-inflammatory drugs used chronically. These include ibuprofen, naproxen, Advil, Aleve, and prescription NSAIDs like Celebrex. NSAIDs are remarkably effective for acute pain and inflammation. The problem is chronic use after 60, when kidney function and cardiovascular reserve are already declining. Mechanism 1. Kidney damage through reduced renal blood flow. NSAIDs work partly by blocking prostaglandins, compounds that maintain blood flow to your kidneys. In healthy kidneys with good reserve, this effect is minimal. After 60, when kidney function naturally declines and many people have underlying hypertension or diabetes affecting kidney health, chronic NSAID use can push borderline kidney function into chronic kidney disease or even acute kidney failure. A study analyzing Medicare data from over 700,000 adults aged 65 and older found that NSAID users showed double the risk of acute kidney injury requiring hospitalization compared to non-users. And once kidney function drops below a certain threshold, it rarely recovers. You've moved from medication for arthritis pain to dialysis dependency. Mechanism 2. Cardiovascular events through blood pressure elevation and clot risk. NSAIDs raise blood pressure by an average of 5 millimeters of mercury, increase fluid retention, and interfere with aspirin's protective antiplatelet effects. Research published in the European Heart Journal, analyzing over 10 million NSAID users, found that even short-term use increased heart attack risk, with the highest risk in the first month of use. Think about the bitter irony. Someone takes ibuprofen daily for knee arthritis to stay mobile and active for heart health. The ibuprofen raises their blood pressure, strains their kidneys, increases heart attack risk, and eventually causes a cardiac event that ends their mobility far more definitively than knee pain ever would have. Medication number 5, glyburide and other older diabetes medications. Glyburide is a sulfonylurea, an older class of diabetes medication still prescribed to millions of seniors despite safer alternatives being available. Glyburide works by forcing your pancreas to pump out insulin regardless of blood sugar level. The problem is, it causes severe hypoglycemia, dangerous low blood sugar episodes, especially in older adults who may skip meals, have declining kidney function that prevents drug clearance, or drink alcohol occasionally. A study from the Canadian Medical Association Journal, analyzing over 33,000 older adults with diabetes, found that those treated with glyburide showed nearly double the risk of severe hypoglycemia requiring emergency treatment compared to those on newer medications like metformin. And hypoglycemia after 60 isn't just uncomfortable. It causes falls, seizures, cardiac arrhythmias, and acute confusion that can be mistaken for stroke. Newer diabetes medications like metformin, SGLT2 inhibitors, or GLP-1 agonists offer better blood sugar control with dramatically lower hypoglycemia risk. Yet glyburide remains on formularies because it's cheap and busy doctors continue prescribing it out of habit. Let me walk you through exactly what to do with this information. First, print your complete medication list. Include prescriptions, over-the-counter medications, and supplements. Second, schedule an appointment specifically to discuss medication review with your doctor. Don't try to address this in a routine visit for something else. Third, for each of the 5 medication categories I discussed, if you're taking them, ask your doctor these specific questions. What was the original indication for starting this medication? Is that condition still present, or has it resolved? What evidence supports continuing this medication specifically in my age group? What would be the process for safely discontinuing or switching to a safer alternative? The key phrase is deprescribing protocol, the systematic process of tapering medications that pose more risk than benefit. This isn't stopping everything abruptly. This is careful reduction under medical supervision with monitoring for withdrawal effects or disease recurrence. For PPIs, the taper typically involves switching to an H2 blocker like famotidine for 2 weeks, then stopping while implementing dietary modifications. For benzodiazepines, a slow taper over 8 to 12 weeks, reducing dose by 10 to 25% every 1 to 2 weeks. For antihistamines, immediate discontinuation is usually safe, but expect rebound insomnia for 1 to 2 weeks. For NSAIDs, switching to acetaminophen for pain or topical treatments like diclofenac gel that don't carry systemic risks. For glyburide, transitioning to metformin or newer agents with your doctor, adjusting doses based on blood sugar monitoring. Here are 5 clinical pearls that make the difference between successful deprescribing and unnecessary struggle. 1. Expect temporary worsening of the original symptom during the first 2 weeks after stopping. This is withdrawal and rebound, not proof you need the medication permanently. 2. Address underlying causes simultaneously. If you're stopping a PPI, fix the dietary triggers for reflux. If you're stopping a sleep medication, implement sleep hygiene protocols. 3. Reduce one medication at a time so you can identify which changes cause which effects. 4. Keep a symptom diary during the taper process, documenting sleep quality, pain levels, anxiety, digestive symptoms, so you have objective data rather than vague impressions. 5. Recognize that feeling slightly worse for 2 weeks while your body readjusts is worth avoiding dementia, fractures, kidney failure, and cognitive decline over the next 10 years. The mistakes I see most often: stopping everything at once and creating a crisis that forces restarting everything, not addressing the underlying cause and experiencing symptom return that could have been prevented, expecting immediate improvement when some benefits like fracture risk reduction or cognitive stabilization take months to become apparent, accepting a doctor's reflexive resistance without asking them to review the current evidence on medication risks in older adults, and giving up after one failed attempt instead of trying a slower taper or different approach. Let's lock in everything we covered. After 60, your body processes medications differently. Liver function declines, kidney clearance slows, brain chemistry shifts. Medications that were protective in midlife become dangerous in older age. 5 medication categories pose particular risk: proton pump inhibitors that block stomach acid, leading to fracture risk, B12 deficiency, and infections, benzodiazepines that increase fall risk and accelerate dementia, first-generation antihistamines that cause severe cognitive impairment, NSAIDs used chronically that damage kidneys and increase heart attack risk, and older diabetes medications like glyburide that cause dangerous low blood sugar. The solution is systematic deprescribing under medical supervision, using slow tapers, addressing underlying causes, and accepting short-term discomfort during withdrawal for long-term health preservation. Aging is not a sentence to accept medication-induced decline as inevitable. You are not obligated to stay on medications started in your 50s just because no one has questioned whether they still make sense. The research is clear. For millions of seniors, less medication means better health, sharper thinking, stronger bones, and longer independent living. Your body has remarkable capacity to recover when you remove what's harming it. The confusion you've attributed to aging might clear within weeks of stopping anticholinergic medications. The fatigue might resolve when your body can finally absorb B12 again. The fall risk might drop dramatically when benzodiazepines are tapered off. You have far more control than you've been led to believe. These aren't mysterious age-related declines you're powerless to stop. These are predictable adverse medication effects with known solutions. I need you to do something for me right now. Share this video with someone you know over 60 who's taking multiple medications. Send it to a parent, a friend, a neighbor. This information doesn't reach people through their doctor's offices because 15-minute appointment slots don't allow for comprehensive medication review. It reaches people when someone who cares about them shares it directly. If you found this valuable, subscribe to this channel and click the notification bell. I publish evidence-based content every week on exactly these topics, the health information that should be standard medical practice, but somehow never makes it into exam rooms. Check out my previous video, where I break down the 5 supplements that actually have peer-reviewed evidence for cognitive protection after 60, not the ones the wellness industry promotes, but the ones with legitimate clinical trials showing measurable benefit. Dr. Liana out.